Hi there, this is Dr. Bill Dishinger, and I am here to present some stuff on Damon passive self-ligation to you. As always, during this pandemic that we've all been going through around the world, it's sad that we can't be together in person, but thankful that we have the technology to share and learn together the way that we have been through all of this. So hopefully soon we'll all be together again, but until then, this is what we got. But I'm going to go ahead and get started. So Damon passive self-ligation, I've been using it in my practice for a little over 20 years now, and it's just been a fabulous addition to what we do for our patients, the treatment outcomes that we're able to achieve, and just the comfort that the patients are able to go through compared to what I used to put my patients through. And I want to just go through kind of some of our criteria of what we look at in cases and how we treat these cases. So real quick, I am from the United States, from the western United States, up in the northwest corner in a state called Oregon, just outside the city of Portland. So that's where we're located, but let's go ahead and start discussing aesthetics to begin with. Every treatment decision in our office begins with aesthetics. And, everybody might say, well, of course, we're orthodontists. Of course, we're dealing with aesthetics. But what I mean by that is I begin my treatment planning by looking at the smile and the face and deciding what those need. And then I go into the mouth and figure out what kind of malocclusion they have and what do I need to do to accomplish those initial aesthetic goals of the smile and the face. And so it's not about just treating to a cephalometric number. It is, of course, treating to class 1 canine and molar and solid occlusion, proper overjet and overbite. I mean, we do those. We always do those. Nothing has changed with that. But it's more than that. It's looking at the whole face. It's looking at the lip structure, the soft tissue, the hard tissue. It's all those things. And that's where we begin, and we work backwards from there. So how do we make that aesthetic decision? Well, as I said, it begins with the face. And so here's an example of a case that comes in, really love her profile, really love her lip structure, love her smile, except for her teeth are a little bit crooked. So we decide, looking at her, we want to protect everything that she has right there. We want to protect the facial structure and the balance. We don't want to mess that up. We look then in the mouth, and there's a fair amount of crowding in there. And so are we going to extract? I don't feel like we need to extract. I feel like we have room to do some arch broadening on her. But what about that overbite? She's got 100% overbite. But remember, looking in her smile, we really love where her upper incisor is at. That's a perfect upper incisor display. So with this overbite correction, we cannot do any overbite correction by upper incisor intrusion. This has to be 100% lower arch leveling. So that's what I'm talking about when I say we look at the aesthetics first, and based on the aesthetics, that's where we build our mechanics. So this is an example of that. And if we look at her finished, we maintain that upper incisor position. See how it's right where we started as far as where it is in the smile arc, the vertical dimension with the smile line. We broaden the arches so that we gave a little bit better filling of the buccal corridors. We maintain her lip position. We did not retract the incisor, so it's a non-extraction case for her. But let's look at the overbite correction. That's an ideal overbite finish now. So 100% of our overbite correction we accomplish by leveling the lower arch. And again, setting up your mechanics to give the perfect facial and smile aesthetics. There's a lot of different ways that orthodontically that case could have been treated, but not if we want to give the maximum aesthetic result facially and smile-wise. So that's what I'm talking about when I say it begins with the face and it begins with aesthetics. So there she is at the start, and then here she is finished after 18 months of treatment. And again, looking at that broad upper arch, which we talk about with the Damon system all the time, filling in those buccal corridors, but that overbite correction, again, maintaining the profile and maintaining that smile arc. So that's facial aesthetic orthodontic treatment planning there. So here's a different example. This is somebody that has a profile that we don't really like. We want to bring that mandible forward. So we're looking at that facially and we have to decide, okay, what are our options? We want to enhance that. I actually personally like her upper lip. I like fuller lips, especially in females. But I want to bring her mandible forward and that lower lip forward to then match where that upper lip is at. So in our consultation, we'll use some imaging software and I'll do a little bit of morphing of that image and show them this is what we want to have you look like. So this is the same picture. I just morphed it a little bit. I did a little bit of editing on it and showed them what it would look like by bringing the mandible forward. Here she is at the end of treatment. And I think we pretty much hit the mark on what we were trying to accomplish with her profile change. See how much more balanced she is. See how her upper and lower lips and chin now are well within where they're supposed to be. So I used an advanced sync Herbst appliance for her to bring the mandible forward. And I'm not going to get into advanced sync treatment in this lecture, but that's how I accomplished that with her. Here's a completely different type of profile. This is Judy, and Judy feels like she's a little bit too protrusive with her upper lip and that kind of whole upper region. I personally didn't mind it so much. As I said, I prefer fuller lips, but she didn't like that look. But more importantly, intraorally, she didn't like the flared upper incisors, and she did not like that excess overjet that she had. She's class 2 on both sides, so that previous patient, we wanted to bring the mandible forward to match it. On Judy, though, we want to do upper retraction in order to enhance her smile aesthetics and her facial aesthetics. So it's a completely different treatment plan, even though they're both class 2. So for Judy, it's a different method that we're going to use to treat her. And we want to reduce that upper incisor protrusion and reduce a little bit of the fullness of the upper lip. That was her main complaint of what she wanted to see changed. And this is Judy finish, and you can see how much softer that upper lip is. And if we look in the mouth, notice there's upper bicuspids missing. I did an extraction of upper 4s, and I retracted the upper 3 to 3, so canine and incisors, pulled them back into a class 1 canine, leaving the molars class 2, and uprighting the upper incisors. I don't do a lot of these types of treatments, but this is one that it was a good fit for her. And it's thinking not just every single case is the same. It's thinking, I wouldn't call it outside the box, but it's thinking about how you want to treat every individual patient to maximize that individual's aesthetic potential. And so that's why Judy had upper bicuspids extracted. And you can see the reduction of the overjet. It turned out really well. And that wasn't my first thought when she walked in the door, was taking out upper teeth, because I try not to extract teeth. I'm not as efficient in my treatments when I take teeth out. I'm pretty good at treating patients non-extraction, but with her, it was the right call and it was the right fit. And she was thrilled with the result that we had for her. So a lot of people say, "Wait, oh my gosh, you're a Damon user. You can't extract, right?" We've seen so many lectures and so many cases around the world of these amazingly treated cases with Damon appliances where there's all sorts of crowding and cases that you would think there's no way that could be treated non-extraction, and somehow it's accomplished. And I do have those cases as well. I have non-extraction cases where with traditional brackets in my hands I would have had to extract. But not every case is a non-extraction case. There's some that just need to have teeth taken out. So Judy was one of those. So we'll look at both extraction and non-extraction cases today. Now, one of the knocks that a lot of people said, and Damon users in particular, and I'm a Damon user, but a lot of Damon users have said if you extract, you're going to wind up with a narrow smile. And that's one of the concerns that Damon users have. But not always is that going to happen. Now, the public, they want to have more upright canines and premolars, so they want to have their buccolingual inclinations in a more upright position. So this is a study that was done, and it was done in both the United States and in China, and they had people that are not in the dental field, so just regular people out there, look at different smiles and assess which ones they like better. And they said that they liked the ones where the canines and premolars were upright, not tipped in a little bit. Orthodontists actually said that on more of the cases, the little bit of lingual inclination of the upper canines and premolars were what orthodontists preferred. But it's not about what us orthodontists want. It's not our smile that we're going to be walking around with the rest of our lives. It's their smile. And if that's what they want, that's what we need to deliver. So that's what I would like to deliver, and apparently that's what people want to have as well. So patients prefer more upright canines and premolars over what orthodontists traditionally prefer. So maybe our traditional preferences aren't what we're supposed to be doing nowadays, because society has changed. So this is an extraction case. This was not treated in my office. This is somebody that came into my office to have some new retainers made, but she had 4 buys extracted. That would be an extraction smile that I do not like. This is that extraction smile that the Damon users have kind of knocked all the years, saying we don't want to have that lingual inclination of the upper canines and upper second premolars. So that's an extraction smile that's a negative extraction smile. So that's not what we want. This, on the other hand, this is a gal that I treated in my office who has 4 buys extracted. I took the 4 buys out, and you can see how upright her canines and premolars are. As a matter of fact, I think I actually didn't do a very good job with upper canines. I think they're maybe a little bit too buccally torqued. And so we can have a big, broad smile filling in the buccal corridors even if we take teeth out, depending on the case. We just have to treat it correctly. So look at the difference in the inclinations and the difference in the smile aesthetics. So it's more than just straight teeth, and I think you're kind of hearing me say that so far. But even studies have shown that people out there in the world know that it's more than just straight teeth. And what they are looking at is the most unattractive smiles they felt were patients that had a very flat smile arc. So their upper central incisors did not follow the line or the contour or the curve of the lower lip. So that natural curvature from the canine to the lateral to the central and then back up again, that smile arc. And lay people saw that a flat smile arc was unattractive. So we need to pay attention to that. That was the one thing that they said was the most unattractive in a smile, is a flat smile arc. So that's the number one important thing for people when they come into our office. They don't want to look like they had orthodontics. And I don't know if you ever had a patient say that to you, but I want to have straight teeth, but I don't want it to look like I had orthodontics. And what they're meaning is they don't want to have that flat smile arc. They don't want to have it look manufactured or fake. So we can deliver that. And I showed this patient earlier. She has a very natural smile arc when she walked into the office, and we maintained that natural smile arc by how we treated her. Torque is a really big deal. So the inclination of the upper incisor, how the light reflects off of that, is really important in a smile. And we saw that with that patient Judy that I treated, where I extracted upper premolars and I uprighted the teeth to give her proper inclination of the upper incisors. So we have to be looking at that as well. And what I look at is, if you look at a line drawn perpendicular to Frankfurt horizontal, I want the facial surface of the upper central incisor to perfectly match that. It's very easy to see that on a lateral ceph. You don't even have to trace it. You just look at the ceph and you can see where that facial surface is, and you can tell if it's angled too far forward, if it's upright where we want it, or if it's under torqued and it's kind of leaning behind that. So that's what I look at for my diagnosis. It's very simple, and a lot of you might be thinking that's a little too simple, but it works well for me. And then we just take care of the whole aesthetic package for the whole face, the smile, hard tissue, soft tissue, all of that. So this is a patient that I treated, and if we look at her, facial balance looks really good. I really like where her lips are, where her chin matches. If you look at her smile, she's not giving us a full smile here. So this would be a picture in our office that's we didn't do a good job taking this picture, because we want to see a better, authentic smile when we take our records. But she looks like she has kind of a decent smile with the position of her upper incisor. And so looking at those upper central incisors, they're in a pretty good position with the smile, but again, 100% overbite, kind of like that adult female that I showed a little bit ago. looking at her lateral ceph, where is the facial surface of the upper central incisor? It's flared. So we need to upright that tooth. We need to upright that tooth and get it in a little bit better, properly torqued position. But if we go back, we do have a little bit of room for some arch development. Not a lot, but we have a little bit of arch development room. So she would be in my office considered borderline extraction. And when I have this type of patient in for the consultation, I will tell them, I don't know for sure if I can treat this non-extraction and get those central incisors, upper front teeth is how I'd language it to the patient, into the right position for you. Now, part of it is just that right central is flared. The left central is pretty good. So I think we're going to be okay with her. But that would be some of the languaging that I would use for her. So here she is 7 months into treatment. I'm kind of jumping ahead on this because I just want to show you kind of where we got in just 7 months. And this is some of the power of passive self-ligation, is getting that far in that short amount of time. And if you look at her, we have proper overbite now. We maintained the class 1, took care of that scissors bite there. But look at the arch development. We took advantage of where the areas were that we could. If you look at the upper right side, look, and even the upper left side too, but look at where the upper sevens came in. And I always look at that in these patients. If those upper sevens come in out pretty buccal compared to the rest of the tooth, I know that there's bone there. I know that we have bone to work with, and we can bring the 4, 5, and 6 out to that to match those upper sevens, and we have room for arch development. And if you look at where those sevens started, and then look at the 7 month progress, those sevens are in the same spot, but look at where the 4, 5, and 6 are now, particularly those 6s. That's where we made the change. That's where we got our arch development. That's where we had room to line the upper incisors and retract that right central incisors in particular and get it into that more upright position. If you notice that blue glue that's on the lingual of that right canine, that's a bite turbo. She had too much overjet for me to put the bite turbos on the central incisors, so I had them on the canines. The one on the left canine has fallen off at this point. We're pretty much done with them. And at this point, I should have taken the right canine turbo off, but I left it on there. But that's what we were using to open up her bite. And then I had her wearing elastics from the lower 6s to the upper 4s. See that hook that's on the upper 4 there? So I had her wearing just a little 2-ounce elastic from the lower 6 to the upper 4, and that's what helped me level that lower arch. And then the lower, a little bit of crowding down there, but as we broaden that upper arch, we're able to upright the lower arch and take care of the crowding. Here she is finished, just 15 months of treatment. Again, not a good smile picture there. We're not doing a good job. We need to make her laugh or something when we're taking her smile pictures, because we need to get a more authentic smile so we truly know what we've done for her and where she was at the start of treatment. But it took us 15 months of treatment is all, so pretty efficient treatment for her. I told her it was going to take us about 18 to 20 months. We finished a little bit faster than I had anticipated, and she was a good elastic wearer, and she got there faster. But if we look at her finish, really nice overbite correction, nice broad arch forms. After we took this picture, I did notice that she still had that bite turbo on, and I did remove it. I didn't leave it on there forever. That was not done on purpose. Somehow I missed that, but after we saw the picture, I got her back in the chair and finished it. But one of the things I want you to notice is, as beautiful as this occlusion and the alignment of the teeth and the overbite and everything, look at her soft tissue. The upper soft tissue, the gingival margins, do not look very good. They're very unmatched. And I need to address that, because when she does give an authentic smile, you notice that. So we're gonna change that. If we look at the upper incisor, it's not perfect. It's better, but it's not perfect. I would have liked to have gotten that a little bit more upright. And if we look at where she started to where she finished, again, it's a nice change. I definitely improved it, but I would have liked to have gotten that perfect. Again, though, it's a really nice finish, but there's some detailing I still got to do. When the braces come off, that doesn't mean you're done with the case. So I had her in I usually wait for about 6 weeks after I remove braces, so any inflammation that's there has calmed down, and I truly know what I'm dealing with the gingival margins. I only did 3 to 3 on her. I felt like the 4s and 5s were fine. And whenever I do some gingival recontouring, 95% of the time, I'm doing a frenectomy as well. Almost everybody that has thick gingival tissue in the maxillary arch has a low frenum attachment. And it's that frenum that's causing that tissue to be thick. So almost everybody gets a frenectomy in my office. Here she is 2 weeks later after she's healed up a little bit. We're going to make her a new retainer now to fully cover the enamel. And then here she is a few months down the road once it's fully healed. And you can see just how beautiful that tissue turned out once it's healed up after we've done our laser procedure. So it's those little details. It's not just lining the teeth up. It's all the facial aesthetics and then all the mini micro aesthetics that Dr. David Sarver has taught us for years. And this would be one of those with that soft tissue recontouring. And if we go back, you can see her occlusions actually settled in a little bit better on that right side, which is nice. And of course, she's wearing nighttime retainers. But I do bonded retainers as well. So the picture on the left is the day that we debanded her. On the right is after she's healed from the laser. And again, she doesn't like to smile big for us, but you can see that tissue on that left central incisor is balanced out with the right one now. So I'm going to skip ahead real quick. Let's talk about adults. So, kids are, we can do a lot of things to kids, but, sometimes adults have been more difficult to treat over the years. I have to say I've found with passive self-ligation for that not to be such a problem. And I think it's because of the force levels. With the kids, we can push on teeth kind of however we want to, and they're so good at healing that they'll respond and teeth will move for us. With adults, though, our healing is not as good. We do not recover our bodies the same way that the kids' bodies recover. And so when we are treating adults, we need to be more gentle with how we're pushing on those teeth. We need to be using lower forces. I have found in my hands that passive self-ligation helps me do that in a better way, and I can treat those tissues a little bit more gently, and it just seems like the adults respond a little bit better than what I used to see with traditional brackets. So here's Gian, and Gian comes in, and we're going to use Damon passive self-ligation on him, but that's a lot of crowding. And one of the things I was concerned about is look at his 6s and 7s. They're very broad, so I don't have a whole lot of room to play with. Now the 4s and 5s and then that right canine on the upper arch, they're collapsed in. So I do have room to move outwards in those areas. Now the other advantage that I have with this case is his upper incisors are collapsed lingually as well. And I'm going to advance those labially, rounding out that arch, and that's going to give me some room too. So I felt like with Gian, I had some room for improvement. I had some opportunity. But I wasn't 100% sure. I told Gian, I said, I'm pretty sure I can treat you non-extraction, but we're going to go through treatment for about 6 to 8 months. We're going to see where we're at, and we may have to take some teeth out. But I thought I had enough opportunities there that I could do it. So see, you can't even see the upper central incisors. They're so lingually inclined. So that right lateral was decent, but then the centrals and the left lateral were lingually inclined. So I felt like that was another area of opportunity to treat this non-extraction. So here's Gian the day that we put brackets on. And there's that light elastic that I was talking about earlier. He's wearing a little light 2-ounce elastic from the lower 6 to the upper 4. And we do this on the very first initial 014 copper night tie. It's a 2-ounce elastic, so it's not going to overpower the wire. It works beautifully. We've opened up his occlusion. You'll see here in just a little bit how we've done that. We have open coil springs for our teeth that are blocked out. I'm a big proponent, sorry about that, big proponent of using open coil springs when I have teeth that are blocked out. If you hook an 014 or even an 013 copper nitai into all those crooked teeth, they're going to straighten out. They're going to straighten out fast. But they may go in positions you don't really want them to. You may flare your upper incisors quite a bit, a lot more than you would want. Even in this case, teeth will straighten out, and they're going to follow the path of least resistance. And if you overpower the dentition, they'll fly forward on you. So we use open coil springs to bypass those teeth to make sure that doesn't happen. So again, there's that light elastic. I have the open coil springs bypassing those blocked out teeth. There's those bite turbos. I am able to place them on the lingual, the upper incisors for him. So that's opening them up, and then I'm using those light elastics to level the lower arch, so it's leveling of the lower arch for the overbite correction. On that lower left lateral, I couldn't get a bracket on it, so I just used a little cleat down there. And as you can see, I have the open coil spring bypassing that tooth, but I also am tied back to that lateral. What that does is it provides a reciprocal anchor point. So that lateral that's set back is going to help prevent my centrals from flaring forward. So it's going to give me a little bit of an anchorage, and that helps me. So when you use open coils, tie it to the lingually blocked out teeth as well so you don't flare the incisors. You'll get more lateral development then with those open coil springs. So here's just a month and a half. We're just going to have men, and we're just going to activate the open coils, and we're just going to slowly plug along. But you can see in just a month and a half how he is in solid occlusion now with an overbite corrected. So we're making good progress on that. We're slowly developing that upper arch. It's going to take time. And that upper right 3 really was slow. You can see how much space we've already made on the lower in just 6 weeks. Here we are again 6 weeks later again. Now we're 3 months total into treatment time. And we're getting there on our space correction. Our overbite is 100% corrected now, so we fully have corrected the overbite. And you can see how that arch is coming along. Here is at 7.5 months. If you notice, I'm still in round wire. I have not progressed out of round wire to this point. He's a little bit overcompensated, a little bit overcorrected on the overbite. We have a slight anterior open bite, but we'll recover that. I'm not worried about a patient. When I have an adult patient that starts with an overbite, I'm never worried about overcorrecting that overbite. I know that's just temporary for now. But you can see again, really nice class 1 is being maintained. Nice occlusion that we're developing. He has a lot of tooth reshaping we're going to do. He's got a lot of wear and a lot of pointed canines. So we're going to do a lot of hard tissue recontouring. That arch is looking pretty good. I mean, we have enough room for everything now. So at this point, 7.5 months in, and I told him between 6 and 8 months we would know. We now are set. We don't have to extract. We're gonna get there just fine. So now it's about finishing and detailing this case. I have the overbite corrected. He's class 1. We have all the space. Now I have all this time, because I told him 20 to 24 months of treatment. I have all this time now to get it just right for him. So a few months later, I do some hard tissue recontouring. I do some repositioning of brackets. So I did a pan and reposition at this point, but I also did some recontouring of the teeth. You can see where I've done that, how I've rounded off those canines. Here we are at 17 months. Now I'm starting to get that occlusion to really settle in nicely. Midline's off a little bit, and I never quite get his midline perfect, but he winds up class 1 canine and molar. And I tell patients, some people have a little bit of a midline deviation. It's usually a 2-size discrepancy. I don't worry so much about a lower midline. I make sure I have the upper midline centered. I have the canines and molars class 1. If the lower midline's off a little bit, if it really bothers them, I can suggest some IPR for them. Most patients would prefer not to do the IPR and just leave it. But there's that arch. And see, that right canine just was really a struggle for us. I had a hard time getting it just right. It was really stubborn. got a little bit of small upper lateral, so that's probably where our midline deviation is it's just not quite matching up perfectly with the lower incisors. And here he is finished. 21 months of treatment. I had told him between 20 and 24, so it worked out how we thought. I did see him for 18 appointments. That's more appointments than I would normally like to see somebody for. Not that I don't like seeing them, but that's not quite as efficient as I'd like to be. I want to have my appointments down between 12 and 14. So I saw him a little bit more often, but I was having to see him about every 6 weeks for the first 8 months to continually activate those open coils. So I saw him a lot more frequently in the first half of treatment. Then the second half of treatment, I was able to spread things out a little bit more. But really nice finish here. You can see just a nice solid class 1 occlusion and overbite correction on both sides. Nice developed arches. He turned out really, really well. He's going to get those upper third molars extracted. And look at the upper incisors. I really like that position. Maybe a touch flared on the upper one, but not much. I mean, that's getting pretty nitpicky. I think that turned out pretty nice for him. And if you look in the mouth, it looks good. So looking at where our areas of opportunity were, and then taking advantage of those to treat this non-extraction. Again, there's nothing wrong with extraction when you need to, but if you can treat it non-extraction, that's what most patients would prefer. And he had areas of opportunity that we could utilize to treat him non-extraction, so that's what we did for him. And maintaining the nice profile, the nice balance there. So, is Damon a non-extraction system? Well, I mean, I've already given it away. I gave away that answer already, and you already saw an extraction case for me. But what about someone like this? So this is Caroline, and Caroline, you can see her teeth are a mess. But I also want you to look at her profile. Look at that lower lip. That lower lip needs to be softened up a little bit. She looks class 3, even though she's not. And it's just because that her dentition is so bimax protrusive that it's just, she can't get her lips together properly. And if you look at this patient here, and you look at the amount of crowding that she has, but look at her upper arch. Her upper arch is already broad. So she's got that broad upper arch. There's nowhere for me to take those teeth. I can't broaden it out any further. Her teeth are already flared, so I don't have room to go forward with the incisors. So if I only had to alleviate the crowding, maybe I'd be okay, but she's really flared as well. So there's nothing I can do for Caroline. See how bimax protrusive she is with that amount of crowding. So this is a 4 by extraction case for me. I'm going to take out upper and lower 4s, and I want to do it early on in treatment. She wasn't able to get in and get the teeth extracted before we got the brackets on, but we got the brackets on and got started. As you can see, I'm still using open coils for those blocked out teeth. So I still want to use my coils to direct the teeth where I want them to go. And she's going to go get her teeth extracted very soon after we got the brackets on. So I wanted to use open coils to help guide the canines back into the extraction sites. So that's what's going to happen once she gets those teeth taken out. So at her next appointment here, you can see she's had the extractions done. We're using those coils and a little bit of light elastics to guide the canines where I want them to go. We're creating the space that we need for the incisors, but also to upright the incisors too. Not just alleviate the crowding, but upright them as well. She already had some broad arches, so we didn't have to do any arch broadening, but that's where we're going, is retracting those teeth into the extraction sites. So I like to just let the teeth drift a little bit, kind of like Wick Alexander, the driftodontics that he used to show. And I'll let the teeth drift. I'll guide them a little bit with the springs, but I'm not going to actively retract a canine just by itself. Once I have the crowding alleviated and I have the upper and lower 3 to 3 consolidated, Then I'll do en masse retraction to finish closing the spaces, and that's what we're doing here on stainless steel wires. So I don't want to really do active extraction site closure until I'm in my stainless steels, and I'll do a sliding mechanics en masse retraction. So you can see it's coming along really nicely. We're a year in. I take longer to treat extraction cases. I just do. Here we are at 18 months. I've done her pan and repo after the full space closure, and now we're going to start bringing that occlusion together and just finishing her up for a beautiful result. She already had the broad arches to begin with, and here she is finished. 22 months of treatment, so similar to Xion, 15 appointments, so just a couple less than he had. I wasn't having to do a bunch of open coil spring activation at the start, and so that's where we're able to save some time and some appointments with her overall. But you can see she has a large lower lip that's never going to change, but it's better balanced with the upper lip than where she was to begin with. She's got a nice broad smile, even though she has 4 bites taken out. But a really nice result. And you can see the nice solid class 1 occlusion everywhere. Nice upright incisor, and that was our goal. Remember how flared she was? We didn't have anywhere to go. We had to take teeth out. We had to extract in order to upright those. So can you extract and still have a Damon broad arch? Absolutely. Absolutely you can. She already had one to begin with, and that's why I felt comfortable doing it. But you don't wind up with narrow arches if you extract, if you treat it right. So I mean, that's a great change. So a really beautiful smile. And look at the nice change in her profile. So what about lower incisor extractions? So here's Brenda, and if we look at Brenda, she's had multiple opinions from multiple orthodontists that have suggested taking out that lower incisor. And when she came in to see me, I told her, I said, I think that's a good treatment plan. I think taking out that lower incisor is an easy way to treat your case and really position things properly. She didn't want to have a lower incisor extracted. That's why she had been getting multiple opinions. She wanted to try to find an orthodontist that could treat her without extracting that tooth. I told her, I don't know if I can. I'll try. I said, if you're willing to be open-minded to letting me try, and if we're not getting there, then we can take it out. I'm willing to do it for you. And she said that she was. So we were going to try to treat her non-extraction, but that's a lot of crowding to take care of. But again, looking at the areas of opportunity that we had, very constricted arches. You can see those 4s in particular, the 4s and 5s, how lingually inclined they are, and we have a lot of room to develop those arches, to upright them. So I have areas of opportunity to do this and make the space. Her upper incisors are in a pretty good position already, so I do have to be careful where I move those and make sure that I don't flare them. Same treatment as what you've seen. We're doing some bite turbos. We're going to do some light early elastics. We have open coil springs where we have the blocked out teeth. Now this one's a little bit harder because the blocked out tooth on the lower is labially displaced, so I don't have a reciprocal anchorage to use. I don't have a lingually blocked out tooth, so that made it a little bit more difficult for me. So I was a little bit worried. So you'll see here in a second what I did on the lower, trying to combat that. See how I have the open coil spring going from the right lateral. It's going all the way in front of that right central that's blocked out labially, but it's also bypassing the left central. So I'm tied to that left central. I'm trying to use that as my reciprocal anchorage. It's not ideal, but it's a way to do it. So that's what I'm trying to do to try to control that. So here she is. She's 1 month in, and we're making some space. She's already getting her overbite correction done pretty well. Slowly developing that upper arch. So we're making a little bit of space down there. At this point, I'm like, I don't know if it's going to work. We'll keep trying. Then she comes back at 3.5 months. Look at that. We have a brace on that tooth now. 3.5 months. Her overbite's corrected. Her upper arch is fairly well developed. And look at that. We have that tooth in the arch. Now the lower incisor is a little bit flared right now, so we're going to have to be uprighting them as we're finishing her case, but we're only in round wire right now, so I haven't even started working on torquing them. But that's in only 3.5 months. Remember, this is someone that had multiple opinions that had been told she needed to have a tooth taken out. And I wasn't even sure if I could do it without taking the tooth out. Sometimes, you know, the mechanics just surprise me on what it can do. I forgot to tell her to stop wearing her elastics, so she actually overcorrected her overbite. But again, an adult, I don't worry about that. That's going to come right back down as soon as I tell her to stop wearing them. So she stopped wearing them, and she'll be fine. Left side's looking good though, nice and socked in. But look at the upper arch. We have a nice arch form now, that Damon arch that we're striving for. And now the lower, see how we've gotten those lower incisors upright? She looks great. I mean, we're only 4.5 months in. I have all this time now to get this just right. At 6 months, I mean, she's pretty much done. You know, I mean, what more are we going to do? She looks fantastic. So now I'm just detailing things. I'm just finishing them up. I'm going to do some hard tissue recontouring, a little bit of IPR for black triangle spaces, and we're just doing the little details. And here she is finished. 12 months of treatment, that's all it took us. 10 appointments, that's great. That's great efficiency on a patient that was a difficult case. Multiple opinions had suggested extraction. We did it a different way because of what the patient wanted. We listened to what she desired to have done, and we tried to accomplish it, and we did. Now, we don't always succeed. We can't treat everybody non-extraction that doesn't want extractions, but we can treat a lot of them. And there's that upper incisor. We didn't flare it. Really good position. So we held that upper incisor where we were trying to keep it at. Lower incisor position. Maintain it really well. So yeah, really, really happy with the result we're able to give for her. Meeting the patient's needs and wants, and doing it in a healthy way. Not flaring the incisors. Beautiful smile result. So again, Bimax protrusive cases, do we need to extract all of them? Again, sometimes you don't know. Here's Yapu, and didn't know on Yapu if I was going to be able to make room for those canines. But I said, you know, you're pretty collapsed in the 4 and 5 region. Even the 6s I felt had room to develop. They were a little bit narrow, some mesial rotation on them. So I felt like I could probably get the space made for him. So that was, you know, again, it was we're going to see where we're at in 6 to 8 months, and we'll do our best. So here he is with the open coil springs. I am bypassing both the laterals and the canines on the upper. The reason I'm doing that is so I can use my laterals for my reciprocal anchorage, bypassing the canines, because I don't want to start bringing them down before I have the space. If I bring them down before the space is made, then I'm just going to flare the upper incisors. So we're going to bypass both of those. On the lower, we have crowded out laterals. Not too bad, but a little bit. So we're going to bypass those laterals. And then every 6 weeks, we're going to activate our open coil springs, staying in the light, round 014 copper nightie wires. So I'm just going to keep activating those springs on top. On the lower, we already have the space we need. So we took the springs out and we engaged the laterals. 6.5 months, still making room for those canines. And, you know, some patients go really quickly, like our last adult with that lower incisor, and some take time. But you have to let the body dictate when you move forward. If you try to move forward before the body's ready, then you're not going to be successful in treating these non-extraction. So you have to just keep being patient. So 6.5 months, I'm still in round wire. Here we're at 8 months. Now we're starting to look pretty good with the space for those canines. As you can see, I have the room I need on that right side, more than enough. On the left side, pretty close. The lower arch looks great, but that was a lot easier down there. Now at 11 months, we've got brackets on the canines, bringing them down into position. And now we're home free on our space. So now we have this time to finish it up. I told them to plan on 2 years of treatment with a kind of a mid-treatment assessment of if we were going to be able to do this without extractions. Now he was flared a little bit in the upper incisors, so I did a little bit of IPR and then what we call a sling or a leash power chain on the upper. And so I did some IPR upper 3 to 3, and then I placed this power chain that goes around the brackets of the 3s, but it goes incisal to the brackets 2 to 2. And what that's going to do is going to really introduce some lingual crown torque onto the 2 to 2 to upright those incisors that got a little bit flared in this process. And so when you have a case that's a bimax case with some crowding, sometimes you're going to have to do this. And I tell patients before treatment, I might have to do a little bit of reshaping of your teeth in order for me to do this without extracting teeth. But it really uprights them, and you can see this finish here turned out really nice. 19 months. I told him 20 to 24, so we went a little bit quicker. 15 appointments. I would have liked to have had a little bit less. Like I said, 12 to 14 is ideal, is what we want to be. But you can see a really nice class 1 finish. Upright incisors. Everything's in a good position. Eventually he's going to get those wisdom teeth out. See, upper incisor is in a good spot. It was a little bit flared to begin with, and we maintained or uprighted it a little bit. But a nice finish. So taking advantage where we could there. So what about that mom you promised you could absolutely treat their child without extractions? What about those? So this is Trey. Look at Trey. What a cute little guy. So Trey comes in and he's not 11 yet, but he's got all of his teeth in. He's got these canines 100% blocked out. Both canines totally blocked out. Lower right canine totally blocked out. But look how small his arches are. And I thought, oh man, those are little arches. I have plenty of room. I can broaden this out. This will not be a problem. Yes, Mom, I can totally treat this without extraction. So start off just like we always do with our open coil springs, and I was going to make room. One thing I want you to look at though, and I did not do a good job diagnosing this. Look how flared he is already, and I missed that. See how bimax he is. Pretty underdeveloped maxilla. See where his A point is, where his premaxilla is? He's almost like a class 3 maxilla, almost, is kind of how he is. And it just caused him to be a bimax protrusive case. So I missed that on the diagnosis. And that's my fault, obviously. But here he is at the start of treatment, and just like you've seen, we're using open coils and round wires, and away we go. And that's how we're going to treat him. So no different. Here we are 12 months in. And some food in the braces at the same time. But at 12 months, pretty much got the room I need for the canines. Got that right canine in, just waiting for that left one to come through. I actually wound up using our laser to expose it and bond it. It just wasn't popping through the tissue. Here he is at 18 months. Looks a little full there, doesn't he? Here's his lateral ceph. You can see I'm not making it. There's no way. That maxilla is just it just does not have enough premaxilla or kind of A point, the bone around the apex of the roots of those upper incisors. There's just not enough of it. There's nowhere for me to take these teeth. They're flared. His profile is full. So that promise that I made to Mom, well, I couldn't keep it. I had to take teeth out. So we took 4s out, upper and lower. And Trey is actually my son. So this is my boy. So when I say I take teeth out on some patients, I even do it on my own kids. Taking teeth out is not an evil thing. So despite what you've heard about us Damon doctors, we take teeth out when we have to, even on our own kids. And he had to have some teeth taken out. So this is my boy Trey. I have 4 boys. This is one of my twins, and he's now 14, but he was around 13 when I finished him. He was 12 when I took his teeth out. So I'm doing sling chain on him as well because he was so flared. Even with taking teeth out, I needed to do a lot of uprighting. So as I was closing the extraction sites, I was doing the sling chain at the same time to really make sure I had those teeth upright. So now we're doing our en masse retraction. We have the teeth upright. We're just going to finish closing extraction sites. I mean, he's a little guy. So Trey's little, and he's got big teeth, and there's just nowhere for them to go. So it took me quite a while to take care of this little guy. And it was a hard case. I mean, I really struggled to get him a decent occlusal finish, and never really got him totally perfect, but at some point you can't keep treating kids forever. And Trey's had chemotherapy. He's had a lot to go through in his life. So he's had cancer, and I felt like I'd put him through enough finally. So here he was on the left at the start of treatment. There he was 18 months in, and how flared and protrusive he was. I took the teeth out, and there he is finished. So here he is with his braces off, and you can see the dark circles under his eyes, he's been through a lot medically. And so it's not a perfect finish, but he's pretty good. He's going to live, and he'll be just fine. But I made a mistake in my diagnosis at the start. It took me 18 months to figure it out. I should have figured it out much sooner. With my own kid, I wasn't paying attention, probably like I would have with the patient. I didn't do a full consultation appointment, review of the records. It's my kid. I just started putting some braces on, and definitely made a mistake there, because if I had really looked at the records and really looked at that lateral ceph, I would have taken upper and lower fours out before I put braces on them, and I would have just taken the upper and lower fours out and let those canines drift in, and you probably wouldn't have had to have very much orthodontic treatment if I had done that. So bad job by me as an orthodontist, even worse as a dad, but we eventually got through it. You can see he's got a little arch, a little mouth. There's just not a whole lot in there, but a successful finish despite all that. So again, where I took him to and where he finished. So, is Damon a non-extraction system? Well, remember, it begins with the face. And so, if the face dictates extraction, then we extract. If the face doesn't dictate extraction, then we try as hard as we can not to extract. So, can I treat non-extraction more often than I used to? Absolutely. The Damon system has helped me do that. But when I do extract, Damon makes closing extraction spaces easier for me with the low friction and the sliding mechanics. So real quick, I want to talk about retention, because lots of times I'll hear from people, that can't be stable. Oh, you treated out non-extraction, that can't be stable. Well, from all the studies that they did at University of Washington with the Little research, Dr. Little, they looked at 600 cases for over 35 years. They've actually looked at them for 50 years now. And what did they find? They evaluated extraction, non-extraction, all sorts of different things. At the time, at 35 years, only 30% of cases had stability. It's down to 10% now. Now that we're at 45 to 50 years, it's at 10% stability. So if 70% of these cases are relapsing, and it didn't matter whether they were extraction or non-extraction, that means we have to retain no matter what we do. So whether you extract or you don't extract, you have to retain your case. So if I have to retain my cases, I'm going to treat to the face. and I'm going to retain it no matter what. So here's Bailey. Lots of crowding. Here she is finished, 26 months of treatment. Nice result. A lot of arch expansion. No expanders, just doing it with Damon. You can see we had 6 millimeters of expansion in the canines, 5.5 in the first premolar, 5.5 in the second premolar, and 4 in the molar. That's a lot of expansion without an expander. Here she is, 6 years post-treatment. No nighttime retention. Looks great. It's holding up very nicely. I did bonded retainers, upper and lower 3 to 3 for her, because she told me she wasn't going to wear removable retainers. She's never worn a nighttime retainer. This is all she's ever had. Here she is, 17 years post-treatment. She came in. I'm now treating her children. That makes me feel old. But I'm treating her children now. Again, she's never worn a removable retainer. She's had a little bit of movement. She's had a little bit of movement in the premolars, but not much. So it's held up really nicely. Now, does everybody hold up that nicely without nighttime retainers? Absolutely not. But my point is that we're going to retain people whether we've treated them or not with extractions or non-extractions. So the argument of you should have treated that with extractions because it's going to be more stable, it's an invalid argument. So treat to the face, not to the space. That's a saying that I've heard before. So at this point, although cases treated with the Damon system cannot claim more stability than other treatment methods, certainly it's no more unstable than the research has shown of all orthodontically treated cases. Everything must be retained. So how do I retain? I do a lower 3 to 3 fixed bonded retainer on everybody. Upper, I'll do a 2 to 2 if they had some spacing. So if there's spacing on a case and between the incisors, I'll do some sort of upper bonded retainer. I prefer not to do upper bonded retainers because they just break so frequently. They're so hard to maintain. So I don't do an upper bonded retainer very often, but my lower 3 to 3 fixed is a must. I do that on everybody. And then I make SX clear retainers that they wear at nighttime over that. And I tell them to wear them their entire life. Because how many times does a patient come in that they had retainers for 10 years that broke or they lost, and then now their teeth started moving? Our teeth want to move our entire life. So as long as they want their teeth to stay straight, they should always have a retainer that they wear at nighttime. So let's start with an adult open bite. This is Jake, and as you can see, Jake's class 2 skeletal. He's got a lot of crowding, just looking, just at his smile. If we go into the intraoral pictures, dental class 2 due to that skeletal class 2 pattern, maxillary constriction, anterior open bite, severe crowding in the upper arch, mild crowding in the lower arch. So definitely a lower tongue posture position here in this guy. This is somebody that had always wanted to have orthodontic treatment. As a kid, they couldn't afford it. Once he became an adult, he was told he was going to have surgery or have multiple teeth taken out. None of those options sounded very good to him. And so he came to our office hearing that we can do some different things using our Damon self-ligation. And I told him that I felt like I could treat him non-surgically and give him a good result. So let's kind of dive in a little bit further into this case. Sorry, for some reason we didn't have an initial lateral ceph. We had gotten the Panorex from his dentist. And typically, if we have a current Panorex from the dentist, we won't re-x-ray them, so we won't put them through extra radiation to get that lateral ceph. This would have been a great case to have the ceph for, had I known I was going to be presenting this case, but unfortunately we don't have that. So here he is, 4 months into treatment. And if you listen to my first presentation that I did regarding passive self-ligation, you heard a lot about the open coil springs that we use in order to create the space and how we tie those to the blocked out teeth. I'm not going to spend a lot of time on this. If you want some more information on that, go back to my first seminar that I did regarding that. But we are using open coils, as you can see. And our goals to begin with were to correct the posterior crossbite, so broadening that upper arch. As you can see, we have hooks on the lingual of the upper molars. He's wearing crossbite elastics. Those are 2.5 ounce elastics down to the buckle of the lower sixes, helping to facilitate that broadening out of those first molars. You can see the arch development that we've already gained in just 4 months of treatment, so pretty exciting where we're getting so far. On the lower, because of us inhibiting the lower uprighting by doing those posterior crossbite elastics, lots of times if we have a little bit of crowding in the lower, it'll take us a little bit longer to alleviate that than what it normally would in a typical case because of those crossbite elastics kind of inhibiting that arch development, which is what we want. We don't want that lower arch to all of a sudden just blow open with too much broadening at the start. Here we are 5 months later. Now we're done with the open coil springs. We've engaged 014 copper night ties into those blocked out laterals, and we're slowly going to align everything. The posterior crossbite is looking great. You can see that arch development that we've gained on the lower. We have the space for that lateral now, and we're just going to rotate that tooth around. Now we're just going through our wire sequence and just level and aligning, just getting things into proper position. You can see crossbite correction is done now. Just getting everything kind of dialed in as far as the positioning of the teeth themselves. And we're eventually going to work into placing posterior tads for our intrusion of the molars to close down that open bite. And with Jake, I felt like his anterior smile line didn't really give us the opportunity to extrude the upper incisors. If we did that, we'd wind up with a gummy smile, which we did not want. So posterior intrusion was how we're going to close down this open bite. That's also going to help us in our class 2 correction because as the mandible auto-rotates, it's going to auto-rotate forward a little bit, helping to correct that class 2, getting us more into a class 1 position. And you'll see that in his final photos as far as how he finished. So the way that I did Jake's tads, I did buccal tads between the 6s and 7s, and I had a transpalatal going across the palate. As you can see, I have some hooks built into that transpalatal in case I have trouble with keeping the buccal tads in place. I do my buccal tads a little bit different now. Back when I treated Jake, I was doing them just up at the mucogingival junction, just kind of horizontal. I now go a little bit higher, and I'll actually go into the infrazygomatic arch to get better bone, kind of denser bone for it to secure into. And those work really, really well, and hardly ever do you get any loose when you put them up into the infrazygomatic. If you do them horizontally like I did on these, sometimes you'll get a little bit of loosening of the tads, and you might have to reposition them. So I don't place them that way any longer. So here's Jake about 15 months in, and we're just doing that posterior intrusion and just slowly starting to close down that open bite in front. 17 months, you can see how that is closing down. And it takes time. It's not like it happens real fast with this intrusion. So there you can see I lost the tads on the buccal. They became loose, so I just moved them, took the same tad and just put it into the palate. The bone in the palate is typically a little bit better. I don't like pulling in the palate quite as well because it tends to constrict my maxillary arch. Even with the transpalatal in, it'll kind of roll those molars in. So I prefer to be out in the buccal. But I was having trouble keeping them in place, so that's why I switched them. Now you can see 19 months into treatment, we're just about there on that open bite closure, looking great. But what I want you to notice is see how I'm starting to lose my crossbite correction. See how that upper arch is starting to reconstrict as I'm pulling from the palate. Even with the transpalatal in there, they're rolling in a little bit. So that's why I don't really like to pull from the palate. If you want to pull from both buccal and palate, that's a little bit different using 4 tads because then you're pulling straight vertically. But in this case, that was not the case. At this point, I took the transpalatal off, and you see it looks like he's open, but that's because I've put posterior buildups in because I use the posterior buildups now to hold that intrusion, and I'm just kind of slowly just giving a little bit more pull onto those, just the 6s, but I've taken the transpalatal out because of that problem I was having with losing my posterior crossbite correction. I have them going back into those crossbite elastics again now. So now we're almost 2 years into treatment. We've recovered that posterior crossbite. That looks good now. And now we're just going to finish on detailing the case and just get that last little bit of bite closure and just the finality of the little details of everything. So 26 months. Now we're into the fine tuning of the case. You can see we're into a pretty good class 1 position now. I still have those buildups on, so I still have room for that bite to close down a little bit. See that on those lower 6s. And then here's Jake finished. 28 months of treatment, a lot of appointments. So this was a very inefficient treatment by what I was doing. I was seeing him basically once a month at the early stages as I was activating his open coil springs. And then once I was in the TADS, I was seeing him once a month to reactivate those power chains to the TADS. So a lot of appointments for Jake, but they were short little 10-minute appointments. So sometimes we have to not so much look at the number of appointments overall, but we have to look at the number of minutes that Jake is in the chair. And with most of those appointments, they were 10-minute short appointments. So that's kind of decreasing that time. So it's not as inefficient as it looks first appearance on 27 appointments, but still, if I had been a little bit better with how I place my TADS, how I do it now in the infrazygomatic arch so that I wouldn't have had to pull from the palate, I would have saved some time and saved some appointments, wouldn't have had to go back into the cross bites, and I would have been more efficient. So good lesson learned. But look at that profile change. Remember how we had that class 2 skeletal pattern at the beginning of treatment? If you look in the intraorals, really nice class 1 finish. I would have liked to have gotten the upper canines, particularly that right canine, a little bit more upright. Clear ceramic brackets. I struggle a little bit with torque on those. And we have, with self-ligating brackets, we have a little bit of play in the bracket as well. So when you put a ceramic self-ligating bracket in there, I'm not going to do as well with my uprighting, particularly of a canine. So just a little bit of compromise there, but I would have liked to have gotten that canine better. He's going to get that crown redone on the upper left too. So that's the plan in the future. So here's his finish. Nice upright incisors. Really good class 1 skeletal finish now because of the auto rotation of the mandible. Sorry I don't have an initial ceph to compare it to. But a really nice finish. And it was really amazing because Jake is about, he's a big man. He's about 6'4", really big muscular guy. Kind of looks like just a man's man, just really masculine. And the day I took his braces off, as you can see the change there, he came up to me and he started crying. And he said, "Dr. Bill, I don't think you realize what you've done. I have been ashamed of my teeth my entire life and have never wanted to smile at people. And now I feel like I can smile at everybody, and I feel like my personality can really come out now like it hasn't before. And just thank you. You don't realize the gift that you've given me." That's what it's all about. I mean, that's what we get to do in orthodontics. I did some lasering. I didn't do the upper left too because, as you can see, that margin is already really exposed. And so our plan was that I was going to laser that upper left too right before he was ready to get that crown done. And at the time, he wasn't quite ready financially to do that crown. So we just left that tissue on there for now because I felt it'd look even worse than it does there. So I did that, and then he was supposed to go get that crown redone. And unfortunately, Jake moved, and I haven't been able to finish that lasering in that crown. But he was going to get hooked up with a good dentist in the new town he moved to, and he was going to get that done. So what about an adult severe crowding that has some airway concerns? So this is Kyler, and Kyler has really struggled with airway ever since he was kind of in his early teenage years. He was told that he probably needed to have a double jaw advancement for his airway, and that's just something financially and also just work-wise he just didn't feel like he could undertake. I don't know if you've done many double jaw advancements for those airway cases, but it's a very difficult recovery. It works extremely well, but you have to have a patient that's willing to basically take a month off of work. Kyler wasn't able to do that, so he just wanted to have me see if I could straighten his teeth and help him out with his airway as much as possible. You can see there's a lot of crowding in there, impacted third molars. I mean, he's a mess. He is kind of bimaxillary retrusive, so that's where a bimaxillary advancement surgery would actually benefit him greatly for that airway, but that just was not something that he could take on. Here's the airway tracing, and as an adult, they should be 160 or higher. He's at 91, so he's quite constricted in the airway. So I told Kyler, said, I'm going to do the best I can. I don't know if we're going to be able to treat you without extractions. I don't know what we're going to be able to do as far as giving you more room for your tongue to help improve the airway, but we'll do the best we can, and we'll see where we get. I was a little bit concerned with that retrusive maxilla, with kind of the lack of bone, that as I develop things, would I get a little bit of gingival recession? And that's something that we talked about beforehand. And those are some of the risks that you take on. And when you have a case that's this severe and they're not able to do the ideal treatment, which would be surgery, you have to decide what risk factors are worth taking. And for Kyler, living as he was not a factor he wanted to keep. He just couldn't do that. He did not like his smile and his teeth. As you can see with those laterals all the way in the palate, it's a very unhealthy situation. So that's an unhealthy situation to begin with. By doing our kind of compromised treatment, so to speak, without doing surgery, we're introducing some other risk factors, so maybe a little bit of gingival stripping or recession. So we have to weigh those and decide which is, the lesser of the two evils. And we felt like this was going to be a good solution for him. So that's what we decided to do, knowing that. So wearing some crossbite elastics, as you can see, open coil springs for those blocked out laterals, and real similar to that last case that we took on as far as those things. Not an open bite consideration, so we won't need to be doing TADs, but this is going to be a case that we're going to be in round wires for a long, long time as we're slowly creating the space that we need for all those blocked out teeth. And the key to a case like this is to be patient. As patients come into our practice, we tend to want to change wires. If they sit in our chair, we think a new wire should go into their mouth. And we can't always be that way. We need to make sure that we're looking at what the body's doing, what the body needs, and respond to that. If I would keep increasing wire size on this right here, I'm still an 0-4 copper night tie. But if I kept going into larger and larger wires, and I went into rectangular wires, I would overpower the periodontium, and then for sure we're going to have gingival recession. So 7 months, I'm still in round wires at 7 months. I'm just now hooking into those laterals. As you can see, we are getting some gingival stripping on those upper canines. So something that we knew we were going to get, and unfortunately, it is what it is. We couldn't do anything about it. Sorry, not sure if you can hear my dog barking in the background, but someone's at the door. I'm going to let someone else answer that, but little dog barking in there. So again, just continue to work on broadening the arches, advancing those upper incisors a little bit. As we start losing a little bit of torque control in our round wire there, even with using the open coil springs tied to those blocked out laterals, we're getting some flaring of the upper incisors. We're getting a little bit of, flaring causing that open bite. We're going to recover that, but we're 9 months still in round wires. So the lower arch, I'm into rectangular now. Still 018 copper night tie now in the upper, 1 year in. So you can see the patience that we need to have sometimes. And it's just responding to the body. You can see we're getting a little bit of recession on those upper laterals. Now, part of that will get better. As we bring the teeth forward in that round wire, the crown comes forward, but we now have to upright the roots and bring the roots into the buccal space. It's a lot of root uprighting that we need to do, and as we do that, that tissue will get better. But again, there's risk factors in treating a case like this without surgery and without extractions. Ideally for him, a maxillary sagittal split surgery with a RPE or a MARPE would have been a great situation for him, but that's just one, I was treating him before MARPEs were really widely available, and two, he just, one, financially, and two, just time off work, wasn't willing to take those things on. So we do the best we can with what the patient allows us to do sometimes, and as long as they understand the risk factors, that's okay. So here he is, 16 months. You can see the arch development, how much better that's looking now. And the lower arch was not nearly as difficult. These wires that I have in are called direct wires. They're from Ormco. They're a multi-braided stainless steel wire. So they're a 1925, so a full-size wire, but because of them being multi-braided, they're very soft. It allows us to do a lot of adjustments in the wires and allows us to do some great movements without really putting heavy forces on the teeth. So in a case like this where we are needing to start to introduce some torque, but we don't want to overpower the periodontium, it's a great wire to help us with that. So now we're just going to work on finalizing that occlusion, wearing some elastics to settle things into place, vertically bringing them together, correcting the class 3 on the right side, and just get him done. So that's what we're working on now. I was having trouble getting that class 3 correction on that right side, so I went into a Dynaflex CS2000 spring on that right side. These work really well. You have to do these on stainless steel wires. In the class 3 direction, they're very efficient. Rarely do they break. In the class 2 direction, for whatever reason, if you do it in the class 2, they break quite often. Class 3, they tend to hold up a little bit better. I'm not sure why that is, but definitely work better in the class 3. Now we'll get that last little bit of class 3 correction done for us and finish that up. Now here we are. Now we're class 1. I did a little bit of IPR in the upper incisors and what we call sling chain. You can see where the power chain is around the 4s, and then I do it incisal to the brackets 3 to 3 to help introduce some lingual crown torque. We're adding torque into the wire for those canines as well. Now you can see that's looking much better. Canines are still a little bit flared, but again, with the tissue and the bone, that's probably as good as we're going to get, and we have to accept our limitations sometimes. Here's Kyler finished. One of the things I want you to notice as you're looking at the before and after is that I want you to notice how much weight he lost, and we're going to talk about that in a second. He didn't lose weight because his teeth were hurt with the braces, but again, you can see there's definitely some gingival recession there that he's going to have to address down the road. But he felt like that was a better alternative than doing surgery. You can see how much advancement we got in the anterior. So, with the lack of bone, he's going to have some recession there, and the periodontist was on top of this case all the way through. Look at the airway though, 168 now, which is where I was saying at the start, this is where he should be. Remember, he started at 91. So, I mean, that's almost 100% increase of his airway. Again, a little bit of gingival stripping that he's going to have to deal with on those upper laterals, a little bit on the canines, but not so much, but mostly those upper laterals and that one lower incisor. But a really nice class 1 finish, and look at the change in the arch form there. So again, these are cases where we're not going to get ideal. Ideal is surgery, possibly extractions, most likely extractions or MARPI, and we have to be upfront with the patient when they're not willing or able to take on what that ideal treatment is, and we have to assess the risk factors. For him, he couldn't function. He was very overweight. He couldn't exercise. I want you to look at the difference in his face right here. He told me that his entire life he never had the energy to work out. He was tired all the time. And as we started broadening that upper arch and his tongue got into a better position, he started sleeping better. His sleep apnea got better. He had the energy to do what he'd never been able to do in his entire life. I mean, that's really exciting right there. So that's a life changer. We changed this guy's life. Now, does he have some dental things he's going to have to take care of through his life? Yes, he will. But the trade-off was well worth it, in his opinion, and also in my opinion also. So I'm going to skip through this case real quick, just because we are going to run out of time. Let's look at a posterior open bite. And the reason I'm not going to show that gummy smile is I already showed a TAD case, and it's real similar. It's a gummy smile and TAD intrusion for open bites, almost identical mechanics. But I want to show you this gal. So 21 years old, she had seen an orthodontist growing up, and that orthodontist had told her that she needed to have surgery in order to correct her posterior crossbite and this open bite. And, class 3 on the right side, I don't disagree with that. This is a hard case. But she said, my parents, we can't afford surgery. She's 21 years old now, actually out on her own, taking on orthodontics on her own at this point. She says, I can't do surgery. Can you at least just make my smile, my bite better? Yeah, absolutely. We can definitely improve things. Are we going to perfect things? Probably not, but we will definitely get things better for you. So that's what we set out to do. That's what our goal was. Our goal was not perfection. Our goal was improvement. I was at a meeting one time, and a medical physician was speaking. And he was speaking to us orthodontists. And he said, I don't know why you orthodontists think you have to live in the world of perfection. In medicine, we try to work on improving patients. We're not looking for perfect health. We're looking for health improvement. And that's sometimes what you orthodontists need to have. You need to realize that you're not going to finish everything perfectly. And sometimes you just need to get people better. I thought that was brilliant. That was great advice. And I wish I'd heard that 20 years ago, because I was living in the world of perfection my entire life. And I just, sometimes we're not going to get that. So difficult case here. But 6 months in, we're just doing our normal Damon mechanics, doing some arch broadening, working on some crossbite elastics. So getting that crossbite corrected on that left side. I have some tongue tamers in there because she obviously has a lateral tongue thrust that's getting into the way of that open bite on that left side. But you can see how we're slowly kind of broadening that arch out. We have a definite maxillary cant. I felt like the cant, though, was not one that I needed to do TADs to intrude the right side. I needed to vertically bring the left side together. That's why it's so important to get that tongue out of there. She was working with a myofunctional therapist, a speech therapist, to work on tongue function and tongue positioning to help us, because you might be able to get this bite together, but if you don't have the tongue retrained, it's going to open back up again when you're in retention. So really important that you work on those things. So we're at 9 months. We got some class 3 mechanics on the right side, some vertical elastics now on that left side now that the crossbite's corrected. And we just want to start bringing that bite together. That was our goal, and that's what we're working on. We're fighting the tongue the whole time. Even with myofunctional therapy, it's something that we're always going to fight against. Pretty good class 1 on that right side now. Some good correction there. Midline's still a little bit off. I'm never going to get that midline perfect, but we're not looking for perfection. We're looking for improvement. We're going to do some repositioning of brackets to continue vertically bringing that together. But just using those light forces to develop the arch, and then using light elastics to vertically bring the bite together, we can get there. So we can definitely get a nice result using the light forces of passive self-ligation, the light forces of light elastics, and working with a good myofunctional therapist to help retrain that tongue to be in the right position. So now we're just in the details at this point. And as you can see, everything's really come together nicely. And now at 17 months, I'm just working on finalizing the bite as best that I can. Originally, when we first started, I told her plan on 24 to 28 months of treatment because I felt I was going to be fighting the tongue the whole time. And we got done in 20 months, so a little bit ahead of schedule, but a really nice change, a really nice result. You can see the picture on the right. Skeletally, she has got a deviation. She's got a cant skeletally that, without surgery, we're not going to be able to address. But I felt like we got a really nice result for her, something that she had been told she couldn't achieve without surgery, and we achieved a great result. Now, long term, it's going to relapse a little bit. She's going to have a little bit of opening on that left side. I know that she will. That's just what's going to happen because the tongue's still going to try to get in there. But I have her in a nighttime splint, so an upper and a lower retainer that are luted together with acrylic so that it blocks the tongue from getting in there. So it's got kind of a lingual tongue shield. So that's what I'm doing to try to prevent that as best I can. During the day, she's doing her exercises with her tongue, and she'll do those her whole life to try to keep retraining that tongue. Really, really nice change. Again, she's got a maxillary cant, but there's nothing that we can do about that without surgery, or we could have done some TADs, but I like that right side. It's the left side I would have liked to have brought down a little bit more. So here's a case that I want to show, just showing how we can get room for blocked out canines. So Madeline comes in, and you can see she looks absolutely perfect everywhere except for that left canine. And so we were second or third opinion, and the first couple opinions had talked about extracting the upper left fore and bringing that canine down into place. I think that's a brilliant treatment plan. That's easy. You might not even have to do lower braces. Just take out that upper left fore, bring the canine down, and she's going to be done in less than a year of treatment. You could do that with braces, aligners, whatever you want. They did not want to have a tooth taken out, though. They want to know, is there a way to do this without extracting a tooth? And I told him, I said, yes, it's more difficult though, and it's going to take more time, but we can do it. We have to move that whole upper left buccal segment distal back to where it's supposed to be, because as you can see, the midlines are centered. It's the upper left buccal segment that drifted mesial and blocked that tooth out. We have to put those back in place. A lot of different ways you could do that. You can do it with TADs, you can do it with headgears, whatever. I decided that I was going to use an advanced sync appliance. So that's our Herps appliance that we've designed, that Ormco manufactures, and I only did it on the left side. So I'm going to use it as a distalizer. So as you can see, I have segmented the wire. So the wire ends at that left 2, and so the upper left 4, 5, 6 is its own little segment. I had an overlay wire on the lower. I don't do that anymore. This was a few years ago, and I just had an overlay wire just to kind of hold that lower arch, but you don't need that. But you can see that segment, and here we are 6 weeks in. And in just 6 weeks, you can see how much space that we're already opening up by distalizing that. I don't have any open coil spring going, so this is 100% distalization is what we're going to see. 3 months in, look at the space that we're making. I didn't place my brackets very well on that lower left segment. You can see that lower left 5, so that's something I'll need to address down the road. But look how much space we're just in 3 months have achieved. And so every 6 weeks, we're just activating the arm on that advanced sync Herps appliance and just slowly just distalizing. You're going to get a little bit of tipping. That's okay. You'll recover that once the appliance is off. We almost are there on that space now for that canine. Here we are at 7 months. Now I've placed a bracket onto that canine. I just have a light 018 copper nitide going up to it. I'm going to bring it down. I'm going to leave the advanced sync appliance in place until I have gotten that tooth down, because I don't want the 4, 5, 6 to start drifting mesial again before that canine gets down. So I want to get the canine in place, and that canine will hold that space on its own, and we take the advanced sync appliance off now. We're going to bracket the molars, re-bracket some teeth that we don't have properly positioned, and now we're just going to finish the case. So now we do have room for that canine, no extractions. You can see how we've held that right side ideally. Left side now we have in really good position, just fine-tuning the occlusion. A little bit of arch broadening, but she didn't need a lot. And then here she is, 18 months of treatment, 11 appointments, so very efficient, works really well. This is an easy appliance to use for that. And you can see perfect solid class 1 occlusion on both sides. Canine is in, no extractions. She will get the third molars out eventually, but they're not quite ready yet. Great incisor position. So we didn't advance the incisors to make room for that canine. It was pure distalization of the upper left buccal segment. So, a really fun treatment for us as far as what we could do when you have a patient that is looking for something a little bit different. Again, would have taken out that upper left 4 been easy? Yeah, but that's not what she was looking for. And here she is, 3 years in retention. And you can see how great she's holding up. Okay, so we're going to look at some more cases here. Sorry about that. But yeah, I mean, it's patients coming in and asking for something that maybe is a little bit different than what we would normally do. And that's okay. Sometimes that's what we're going to do. We can't always do the ideal. How about an adult severe class 2? So this is Jan, and you can see Jan's skeletal class 1, but look at her class 2 intraorally. She is a full tooth class 2 on that right side. Constricted arches, but if we look back at her profile, she has pretty thin lips. So we were a little concerned about an upper first premolar extraction scenario. You could definitely do that. You could take out upper 4s and just retract, but we were worried about her profile because of her thin lips already. So we wanted to see, could we get her class 2 corrected? You can see how much overjet she has there, and she hated that overjet. That was her main complaint. Could we get that corrected without taking teeth out because of her thin lips? So again, just our normal Damon mechanics, but there's a little extra thing I did up here on this lower right 4. She has that, or lower right 5. That lower right 5 is facing backwards. You can see it's 90 degrees rotated. So I did this occlusal rotation wire. A friend of mine, Phil Doliak, who's an orthodontist where I live here in Portland, Oregon, this is his invention, and he showed this to me a number of years ago, and it's just brilliant. So here's an example of how we do it. Occlusal wire to derotate bicuspids. So this is actually his case, and you glue these little tubes onto the occlusal surface of the 4, 5, and 6, and then you just put a 0 and 8 copper night tie in there with stops on either side of that 5, and it works brilliantly. So here's the stops right there on either side of that tube on the 5, so you can see how that's going right there. As this wire wants to straighten out, it's going to rotate this tooth out that direction and bring the facial surface where it's supposed to go. Here he is 3 months later. And then here it is at 5 months, perfectly rotated. And you never had to touch that. You just let that wire just do its thing. You never have to make an adjustment onto the wire. Here's one of my cases. You can see that rotated 5. Just in 6 weeks, how we've derotated them. See the change? And you don't have to do anything. You just let the wire do the work for you. And once you derotate it, then you bond it. So really nice. So we take some ligature tie, we put it through the tube, and then we glue it on. And so when you glue it on, you have that ligature tie through there, so that if you get any adhesive into the tube, you pull that ligature tie out, and it'll pull any of that flash adhesive out of it, so you don't have the tube clogged. This is where we get our tubes from. You bond the 3 tubes on the occlusal surface. You thread an 0 and 8 wire through all the tubes. You crimp the stops on either side, mesial and distal, of that rotated tooth, that 5. You have the ends of the wire kind of burned and turned so they don't start poking as they're rotating and sliding out. It works amazing. That's what we did for Jan for that lower 5. In kids, it works very fast. In adults, it'll take some time. I have her wearing some light Class 2 elastics. You can see the bite turbos I have on her canines. On adults, I tend to not put the turbos on the incisors. I tend to put them on the canines. It's just a little bit more comfortable for those adults. They have a little more difficult time adjusting to them than the kids do, so I tend to put them on the canines for adults. Plus, she had so much overjet, they would have been really, really long, and that just would have been way too uncomfortable for her. But you can see the arch development that we're getting. The lower was hard. There was a lot of crowding down there. With the arch form that was already fairly broad. Plus I'm having to use that open coil spring to create the room to allow that 5 to derotate. So the lower took a little bit of time to get it set. So again, just wearing those Class 2 elastics, she's getting some pretty good correction already, as you can see. Arch form's developing nicely on the upper, and you can see that lower right 5, how we're really getting it derotated. We put a bracket on it a few months later. Again, great arch development. That's that Damon arch form that we talk about. It happens in adults, and you can see with her, hers wasn't a necessarily palatal constriction, because look at where her 6s and 7s are, nice and wide. So this isn't a narrow palate. This is lingually inclined 3s, 4s, and 5s, a little bit of the 6s. So it's just uprighting. That's all we're doing. And uprighting is easy to achieve, even in adults. On the lower, you can see all that extra space we created for that 5, and now we're going to be able to close that. And she's looking really nice 11 months in. And this is, again, she'd been told her whole life she needed to have surgery to correct this or have upper teeth taken out, neither of which she was willing to do. So we came up with an alternative that she was excited about, that she felt good about. You can see now that we've got everything consolidated on that lower. She's nice Class 1 on both sides now, just a little over a year into treatment, something that she had been told could never happen. And now we're just doing the fine tuning. So now it's just the details. That's what's so great with the efficiency of the Damon passive self-ligation system. I get a lot of the hard work done early, and then I have time to really detail in the case and get it the way I want it to be. 22 months of treatment, and look at that smile. Look at the lip support. So we didn't retract the lips in correcting that class 2. She still has the same lip position as what she had to begin with. Great solid class 1. Nice arch form change. I don't know why she's biting a little bit forward here, but I just wanted you to see the torque on the upper and lower incisors. We did not flare the lower incisors with all those class 2 elastics we were using, because we always kept our elastics at 3 ounces or less. So we started with 2 ounces, we went to 3 ounces. That's as heavy as we ever got. And that's the key. If you can keep your elastic force level down low, you will not flare the lower incisors. You can keep them upright. So great finish. Again, something that she had been told was not possible, but obviously it was, and it was accomplished. Look at the change in that smile. I mean, she's just thrilled. Look at that. Man, that's fantastic. That's just great right there, what we can do. So class 3, using some buccal shelf TADs. This is Meng, and you can see really significant class 3 on that left side. Lower midline shifted. He's missing lower right molar. He wanted to have that space closed as well. So kind of a lot going on with this case. It's fairly difficult. So he wanted me to protract the lower right 6 and 7 and then correct the class 3 on the left side. So definitely going to be utilizing some TADs. So 18 months of treatment at this point. I've already corrected the class 3 on the left side. I did a buccal shelf TAD over there between the lower left 6 and 7. Retracted that lower left all the way back, getting it into a class 1. Once I achieved that, I put some TADs over on the right side and started protracting the molar. So I did them separately. I probably could have done them together, but I was afraid that by trying to close that right side, by trying to close the space on the right side, it would inhibit me from correcting the class 3 on the left side. I might have been able to do both at the same time. There's that buccal shelf TAD. If you can see that right there, see it's vertically in the buccal shelf between the 6 and 7, so the roots are able to slide past it because it's vertical. We have a Nitai spring from a hook on the wire back to that TAD. It just pulls this whole buccal segment distal and corrects that class 3. It's an amazing treatment that has been perfected in Asia over many years, in both Korea, Taiwan, and some other countries. Dr. John Lin and of course Dr. Chris Chang are some of the pioneers in that, and I saw them present this about 10 years ago, and it was just amazing. I've been doing it ever since with really good success. You can really treat some severe, significant class 3s non-surgically. Again, surgery is the ideal treatment for these patients, but many patients can't or won't go through surgery. So now we're just going to slide those molars forward on that right side, and we're going to close up that space. So again, the buccal shelf goes right there vertically. And these are some images from Dr. Chris Chang. They work really well. It's a great program to correct those class 3s. Long treatment for me, 38 months. But look at how we closed the molar space on that right side, corrected the class 3 on the left side, non-surgically for everything, no implants in the future. So that's a pretty good service for him. Was the treatment longer than if we'd done the ideal treatment with surgery and an implant? Absolutely. But financially long term, he was really happy and excited with what we were able to accomplish. So sometimes, it's not about the ideal, it's about meeting the patient's needs. And I think you've heard that theme over and over again today. And this isn't about saying, oh, Damon can solve everything and you can treat all these cases without surgery. Because I do surgical cases, I do implants. But it's for these patients that's just not an option for them, whether financially or whether with work, they can't miss work, or just with their life, with kids, whatever it is. We have to have alternatives for them that can meet what they need. And this is allowing us to do that. I showed a class 3 spring earlier. This is a great case, though. I just wanted to show with how severe this is. This is a case that we treated for free, for no charge. He had immigrated to America from, I believe it was Laos or Vietnam. I can't remember. I'm sorry. But obviously not very good dental care his whole life. Again, just can't stand his teeth. You can see that upper left central completely broken, and just there's no way he can do surgery. Even getting teeth out is questionable, and with all the compromise he had, I didn't really want to take teeth out because I don't know long term if he's going to have some teeth that wind up needing to be extracted anyways because of health reasons. So I wanted to try to keep all the teeth in there just to give him options down the road in case he started to need to have extractions done due to the health of the teeth. So really hard case that I'm not going to treat ideally. I'm going to do the best I can for him to get into the right spot. Class 3 skeletal anterior crossbite, as you can see, really constricted maxilla. So again, just like you've seen before, open coil springs to begin with, and we're going to be patient at the start. We're not going to be in a hurry. We're just going to patiently develop these arches. We're going to wear some light elastics once we kind of start getting, a little bit more of our space made, and just slowly work on that class 3 correction. Slowly gain the space that we need to. Again, you've seen this in so many cases already in this lecture, but 10 months I'm still in light round wires, and you have to be patient. You can't worry about not changing wires. You can't overpower these. And I just tell the patients, you're going to come in and we're not going to be changing your wires. We're just going to do little adjustments, and that's because we're working with your body. And just whatever your body's going to allow us to get is what we're going to work on. So now we are 13 months. I still am making room in the upper arch. I mean, isn't that amazing? Still just a round wire in the upper. I finally have a rectangular in the lower, but I'm still a round wire in the upper. Still working with open coil spring. Finally, we're done with the open coil springs. 16 months of treatment. I added some molar buildups because I want to now start working on that class 3 correction. You can see how we finally have those teeth engaged. Now at 25 months of treatment, I have some pretty large molar buildups, as you can see, so we can clear the incisors. I have now added those Dynaflex springs, and here it is. CS4 is what they're called now. It used to be CS2000, but CS4 is the name of it from Dynaflex now. It's a great spring. It's going to get us that class 3 correction. And it's about utilizing the tools that are available to us. And these help us get that last little bit of class 3 correction that we can't get with just the elastics. So again, just letting these springs work, slowly getting that correction. You can see how we're getting overcorrected now. Really hard with as worn as those upper incisors were and broken to get the proper overage yet. So I had to do a little bit of IPR on the lower. See, we're finally getting there. Stepped up that left central because I want to get the gingival margins balanced, and then I will build up that left central. So I do finishing elastics on all of our patients. This is not him, but this is just an example of how I do my finishing elastics. I section the lower wire 3 to 3. There's no posterior wire in the lower arch. I keep a full upper arch though because I want to make sure I don't roll in the upper 4s, 5s, and 6s. I want to keep them upright. And then they wear a 2-ounce long elastic. It's an ostrich in the Ormco pack. And they start on the upper 7, and they go to the lower 7, and then they go 6, 6, 5, 5, 4, 4, 3, 3, and end on the upper 2. So it's a zigzagging up and down rubber band. And they will wear that full time for 2 weeks, taking them out to eat and brush. It's difficult to wear. I'm sure I don't get 100% compliance on most of our patients, but I just want them to wear it as much as they can. I'll do a virtual check then after 2 weeks. So we virtually we'll use our app to have them submit some pictures, and I'll check the bite. And if things look pretty good, I'll have them go to nighttime wear. If it's not there yet, I'll encourage them to really try to keep going full time, or I won't be able to get their braces off on time. If things look good, a week later they come in and we remove the braces. So it's a 3/4 inch 2-ounce elastic, as I said. Lower wire section canine to canine, no wire in the posterior. Up and down rubber bands. full-time for 2 weeks, then a short occlusal check. I do those virtually now. We're at nighttime for the last week, as long as it looks good, and then we take them off. I want to do them on our finishing wires, either 1925 stainless steel or TMA in the upper, and a lower 1625 stainless steel. So he's just started his finish elastics. You can see how I have that lower wire sectioned. And here he is finished. The day I took his braces off, I went ahead and bought a composite on that left central for him, and he's going to eventually get that redone from a dentist. But I just did it just so the day he gets his braces off, it looks really nice. You can see, I mean, it's not a perfect finish, but when you think about what we started with him, that's pretty good. You can see the roots all look pretty good and healthy. We advanced the upper incisors some, but maintain pretty good torque. I mean, that's a pretty darn good change. And again, someone that surgery was not an option. I didn't want to take teeth out because I just wasn't sure long term the health of his teeth, if he was going to wind up needing to have some extractions down the road because of their health. So I didn't want to sacrifice teeth now, not knowing what the future held for him. And just, it's a compromised treatment, but it's finding that right fit and still delivering a good result. I mean, look at the change in his smile. So I'm going to finish with this case. And the reason I want to finish with this is because I just want to show the power and just how we can affect people's lives in such a positive way. And this relates to using 3D cone beam imaging. I have an iCat Flex machine in my office, and I just love it. It's definitely changed the way that I practice. But this is an amazingly powerful example of how we can impact people. So my front desk comes up to me. Dr. Bill, there's a woman in doctor's chair. That's kind of our little mini consult room where I can talk to parents. That is not one of our patients, but would like to talk with you about her daughter's orthodontic treatment. So that's always kind of like, I'm not sure if I even want to have that conversation, because it means that something's probably not going right at another orthodontic office and they just want to talk to me. So I didn't really know how to respond to that. But this woman came in and she's basically in tears. And she says, I'm so sorry to come in unannounced without an appointment, but I was driving my daughter to the oral surgeons. And in driving to oral surgeons, I was passing your office, and I've heard of your office, and I just didn't feel right about what we were doing. We're on the way to the oral surgeon to have 2 teeth extracted. And I'll talk about that in a second. And she goes, there's just this feeling that came over me that just maybe that wasn't the right thing for me to do. And I wanted to get your opinion of what you thought, because it's just not settling right for me. I said, well, okay, do you have any records? She says, yes, I have this x-ray. So here's the x-ray that she hands me. I said, okay, so what teeth are they taking out? And she points and she says, we're going to take out this tooth right here, so upper left 2, because she goes, the surgeon and the orthodontist think that there's been damage to the root of this upper left 2 right here, and then they're going to take out this one as well to balance it. So I think in 22 years of treatment, I think I have taken out an upper lateral 1 time. And that's because there just wasn't even a root existent on it. And this gal is as you can see, she's not very old. She's about 10 years old. And that just seemed like a lot. And I said, well, I'd love to take an x-ray with our machine that will give us 3D images of it, and we can really look at that root and see how much damage is done to it. So here's my x-ray. This is off of our iCat, and this is the Panorex that we built. And you can see, it looks to me like that entire root is right there. It looks like I can see the apex. But we're going to build this out into images, and we're going to look a little bit closer. Here is that canine. There's the lateral. It's close, but it's just a little bit away from it. Here's another image going a little bit further in. And that lateral root's healthy. Here's some more cuts. the entire lateral root is intact. Zero damage. Zero damage to the root of this tooth. So look at that. So I show this to Mom. Again, this is in the middle of my day. They don't have an appointment, and I'm doing all this. I said, I tell you what, don't go to the surgeon. I will call her later today, and I'll talk to her, and let's figure this out. So I call the surgeon, and I say, I took some images. Mom just stopped by, and I'm not. This isn't me questioning you. I'm not trying to do that, but I don't see any damage, and I did as many cuts as I could off my cone beam. And I don't see any damage on the root of those laterals. This is the right lateral, and you saw the left lateral on the previous. And the surgeon says, well, I always felt a little bit uncomfortable about this, and didn't feel right about it. And so yeah, I'm glad that they're getting another opinion. So here's Isabel's pictures, and you can see she definitely has some crowding. So we have our work to do to make room for those canines, but we can do it. Again, here's some of the images. So I asked the surgeon, do you have any other images other than just that Panorex? Did you have a cone beam? She says, yeah, we have a cone beam. I said, well, can I see those so I can see the damage to the root of number 10, that upper left lateral? So here's the images that they sent me. And I'm no radiologist, but I can't tell if there's damage there or not. These are really not very good images. This is what she sent me, and this is what they're basing their whole diagnosis off of for extracting those laterals. Now, can you imagine that surgeon, if she did take those laterals out that day, and she pulls that root out, and she looks at it in her hand, and it's perfectly healthy? Can you imagine the feelings that would be going through that surgeon's mind at that point? Does she tell the other orthodontist that ordered these extractions her findings, or does she just hide it or cover it up? So I just thought, how you can't base this decision off of poor radiograph images. You have to. So again, this isn't an advertisement for the iCat machines, but you saw the difference in the images. It's night and day how much better they are. So I had the canine exposed and bonded, and I just started pulling it distal away from the root of the lateral. That was all we were going to do at the start. We're just going to pull it away from the lateral root. We talked about possibly uncovering that left canine or the right canine as well, but we felt like it was going to be fine once we made the space, so we didn't uncover it. Looking back as you watch this case, I should have, but we didn't at the time. So here you can see the initial on the left, how close the canine was to the root of that lateral, and now we're moving it away from that lateral root. Just in 2 months, the progress that we're making. So just pulling that distal away from that lateral root, 6 months, and we've pretty much got it away, and we're safe now. So now we're going to put our braces on. Now that we have that root protected, I can put a bracket on that lateral. And we're going to start making space. And we're going to bring that canine down. So there's that canine. Now, unfortunately, the right canine decided it didn't want to come in. So we went for a while just kind of treating everything else. 12 months of treatment, it's still not in. Everything else is looking great at this point. That canine hasn't moved. So I told the palm, I think we should get that canine exposed and bring that one down as well. The daughter doesn't really enjoy oral surgery. I mean, who does? But she did not enjoy oral surgery, and she didn't want to do that. So they asked if we could wait a little bit longer and see if it came in. It didn't. We finally did expose it. Here she is at 32 months, finally got her braces off. I waited for that right canine for a long time. You can see she was crying that day because she doesn't like dentistry, and getting the glue taken off wasn't her favorite thing. But look at that. She's got all of her teeth in there. She's missing a lower incisor, so that's why the midline looks off, but she's missing a lower incisor. But those upper canines and laterals are all in place, all intact. Look at the roots. Roots are perfect. No damage was ever there on the laterals. Look at that. Perfect healthy roots. So, that really would have been sad to extract those 2 teeth. So proper diagnosis is so important, and having the proper imaging to make sure that we make the right decisions. Again, I've talked all along about listening to what the patient wants and what their desires are. And, this mom spoke out for her daughter and advocated for her daughter. And thank goodness that she did, because we would have lost 2 perfectly healthy teeth had she not advocated for her daughter. So I'm going to do some lasering on her. I wanted to do it that day, but again, she doesn't like dentistry. We had to kind of talk her into it. So here she is the day that I did her frenectomy and a little bit of gingival recontouring, upper 3 to 3 there. This was 2 months after we took the braces off. Here she is 2 weeks post laser healing. It's not quite all the way healed, but it's on its way. And there she is, start to finish. What a great gift that Mom gave her. So thank you. As always, it's been an honor and a pleasure to virtually be with you today. Hopefully soon we can all be in person, and we can quit looking at just our computers, and we can actually shake hands and learn in person from one another. But thank you so much for taking the time to listen in and hopefully learn something. And I look forward to working with all of you in the future.